Good evening, Facebook Live and all our other live streaming platforms. Welcome to the first episode in the 6th season of Endo Summit Live. We are kicking off this season, and our whole season is mostly dedicated to imaging and advancing surgical care for the person with endometriosis. We are kicking off this season with Dr. Mauricio Abrao. Dr. Abrao, can you introduce yourself?
Yes, thank you so much, Sally. It's a big pleasure and an honor to be here with you. I am Mauricio Abrao from São Paulo. I work at São Paulo University and Hospital Beneficência Portuguesa, and past president of AGL, and a very good friend of Andrea and Sally's. It's really good to be here with you.
We are so excited to have you. This is the first time we've had you. It's really an honor, and it's so late there. We're gonna try to get started. On Dr. Vidali, do you want to introduce yourself? Sometimes people complain I don't let you introduce yourself.
A very short introduction. I am a reproductive endocrinologist, a reproductive immunologist, and an endometriosis surgeon. Of course, I lack the credentials that Professor Abrao has, so I'm going to pass immediately the word to you, Sally, to talk a little bit more with Professor Abrao and ask some questions.
Excellent. So for those of you that don't know, I'm Dr. Sally Sorrell, a pelvic physical therapist and person with endometriosis. And together, Dr. Vidali and I make up the Endometriosis Summit. So Dr. Abrao, I think there is an ongoing debate in the endometriosis community about superficial endometriosis and imaging. What is your opinion? And you've done extensive research, so it's a research-backed opinion on detection of superficial endometriosis.
We did some studies in the last 15 years, Sally, on imaging for endometriosis. Not because I am a radiologist or a sonographer, but because as a surgeon, we think that for us to be more successful in the treatment of endometriosis, we need to map the disease before the treatment. In this way, we started working with deep endometriosis, ovarian disease, and nowadays, we are finalizing some studies showing that even for peritoneal disease, superficial disease, it's possible to use imaging. And for sure, as we published 2 years ago in a journal called Human Reproduction, this is time to avoid thinking of diagnostic laparoscopy. We need to have imaging to plan better surgery. We need to have imaging to classify the disease properly. Now we have the AGL stage system that is a very nice system for us to move ahead, and to have better results, to have lower complication rates. So this is time of thinking of planning properly the treatment of endometriosis.
Dr. Vidali.
Beautifully said. I like to underline that when Dr. Abrao talks about diagnostic laparoscopy, he refers to a laparoscopy where somebody just looks and does nothing. And that used to be something that, we used to do in the old days, where people would just look without any intervention. And I think it's a good idea to get away from that. I mean, I don't think that we should encourage people because whether one likes it or not, even a diagnostic laparoscopy is a surgery, it's an operation. So even though it's a small operation, so the idea is that try to get all the information that you can and avoid an intervention. So like the value of imaging is really, really major. And, but, there's always the big question mark. And I think the biggest concern that in the endometriosis community, in the advocate community, has been that the fear is on part of people with endometriosis is that they're going to be told they don't have endometriosis when instead they do. And then the diagnosis is going to be delayed even further. Any comment on that, Sally?
Actually, we just did a webinar at AAGL, and I think that Dr. Abrao said it best. See, we were all listening, that negative imaging results, but a person who has every symptom is not the reason to deny surgery, right? It's part of extensive planning. Now, I do, how do you both feel about that before I go on?
Mauricio.
No, I agree with you, Sally. Of course, the more trained radiologists, right? It's very rare for them to leave disease behind when they are doing a good imaging. But of course, the idea is to plan properly and to excise the lesion, right? We forget talking about ablation, but we need to excise the lesion. And for us to know precisely where is the lesion, how to excise, how to plan, the multidisciplinary team, imaging is superb for this purpose.
So I think it's interesting. So it's been quite a number of years, but I will say the last year before I was diagnosed, I had 14 MRIs, all of which they said were negative. And I had about, I think the number was 11 ultrasounds. Now, how they missed an endometrioma, I don't know. But what are some of the advances that stop that from happening? Because when I went in for surgery, we really thought it was diagnostic, and then it was a 6-7 hour surgery with an overnight stay we weren't prepared for. That's the goal, is to make sure everybody's prepared. So let's talk about some of the advances. Dr. Vidali, you went to Brazil to be trained.
Mm-hmm.
How did that shape and train and change your practice?
Well, I'd like to say I'm going to answer this question, but before that, I'd like to make a quick point, which is the reason why I went to Brazil to train, besides the fact that I have a friendship that goes back a very long time with Mauricio, is that Mauricio really is the person who actually was one of the key people in the world to initiate the movement of diagnostics of endometriosis, proper imaging for endometriosis. And I was not the only one. And Mauricio, I'm going to ask you to tell your story, but let me just talk about my experience going there, and then I would like to ask you to tell your story and how it all started. But the reason why I went there was because I wanted to go somewhere where they had it down, because it's not, today, if you are a doctor and you order an ultrasound in a radiology center, or you do your own ultrasound, you don't necessarily do a good job because you haven't really been trained. That's really one of the biggest problems. I always tell people that the eye cannot see what the brain cannot imagine. So if you don't know what you're looking for, you'll never be able to see it. And it's really funny because I see a lot of patients today, fertility patients especially, that have had ultrasounds by their fertility doctor before IVF, and the doctors don't see adenomyosis, for example. It's typical. Or they don't see endometriosis, they don't see deep endometriosis in the rectum. So I wanted to go see with my own eyes the system, the methodology. Is not just being trained in ultrasound, it's figuring out how to incorporate advanced imaging in your practice. That's really what it is in a practice of endometriosis. Mauricio, you want to tell your story a little bit, how this movement that you started all started? Because really this is your thing in a way, and a lot of people are taking credit for it when you really were the initiator of this. And I know that you never say that, but I'm allowed to say it, that you were the initiator of all this movement.
Thank you, Andrea. But we started thinking of this since the 90s, because in the 90s, we were thinking of, I work in São Paulo University here. That is a huge university, probably the biggest university in Latin America, with brilliant people coming from this university, this medical school. And in this hospital, that's a huge hospital, we had a big line of patients waiting for surgery in the 90s or even more recently, right? And I thought we need to have a way to define who needs laparoscopy or who doesn't need laparoscopy. And we started looking for markers, right? We published some studies on markers for endometriosis. We did very, very nice studies, but of course, the sensitivity of the markers is still not good for this purpose. So in 2000, I approached a group of radiologists, and mainly Manuel Gonçalves here in São Paulo, that was the head of the division of ultrasound of a big institution here. And I told him, Manuel, come to the OR. Let me go to your ultrasound room. Let's talk together. Let's define a protocol. Let's design a project. And we did a very interesting prospective study comparing ultrasound, MRI, clinical exam versus laparoscopy, right? And we realized that if we do a very good ultrasound, training very well the radiologist, right? Bringing him to the OR for him to know what what really need to see during the procedure, right? And with a specific protocol. And which protocol is this? A very simple bowel preparation, because if we remove gas and stool and feces from the rectum, it's much easier for the radiologist to see behind the uterus, right? So when we did this protocol, we published this study, we realized that this was the way to go. And after this, many other studies from our department, from other places came to reinforce that this is the present and the future, right? And we started training people from all over the world. We trained the people, more than 20 radiologists in 10 years from Australia, for example, and they expanded in Australia for a huge number of people, the concept of imaging for endometriosis, the concept of ultrasound. People from Italy, from Spain, from Cleveland Clinic, from Mayo Clinic, from other places from the US came to São Paulo to train. And now we need to, of course, expand this concept. Of course, we need to disseminate the new protocols for this purpose. But of course, we are talking about quality of life of these patients that suffer a lot of this disease, the successful of people, and of course, to reduce the recurrence rate that in most of the cases, we're not talking about recurrence. We're talking about persistence of the disease, because most of these patients were not treated with using imaging before.
Very, very important work.
Mauricio, I know you're on your own a very good ultrasonographer. One of the things that I notice as, I've been interviewing people who completed a MIGS fellowship, is that a lot of MIGS fellow have received no training in ultrasound, virtually no training. They really don't know. Whatever they learned in residency, that's all they learn. And now they do their fellowship, they learn a lot of things, but they have no training in ultrasound. Do you think this is, I understand that you can't know everything, but don't you think that some level of ultrasound training should be part of a MIGS fellowship?
Of course, we
And I'm not criticizing anybody. This is just a training system, you know, but people come and ask me, I want to be trained for ultrasound. And I'm like, what? You just finished a MIG fellowship of 2 years? Sorry, Mauricio.
No, there are some colleagues, Andrea, from different parts of the world. And I was asked to have a meeting tomorrow with some colleagues from Australia, for example, that are asking if the surgeon is not the key person to do the ultrasound, right? Or if we can train people, like you're saying, right, in the fellowship. And you know that here in São Paulo, we have one of the international fellowship programs from AEGL, right?
Mm-hmm.
That is a 3 years program that we are changing to 2 years now, but this is a strong concept, and they interact a lot with ultrasound. I think that to train them for ultrasound is a good alternative, but perhaps for the very specific imaging technique, it should be someone dedicated to this purpose. But for someone to know if you have the ultrasound in your practice as a surgeon, there are some things that are very easy and important for you to know. For example, sliding technique, right? That is when you use the probe for ultrasound to check if there is a cul-de-sac obliteration for endometriosis. If there is an adhesion there, that the structures, the uterus and the ovarian ovaries, they don't move, right? So things like these are very feasible for us to check, even if I'm not a sonographer. But for me, as we expend a lot of time seeing patients, doing surgeries, I don't see myself as the best sonographer, the best person to do it. But again, you are mentioning something that is important. To have this as part of the training, of the fellowship training, is a possibility for us to expand the concept.
It's interesting. We're working with our new branding tonight. So you can see in the corner next to all the little faces is Dr. Orati. And when I told her we were doing the ultrasound course, the first thing she said was, is there some sort of certificate? Are you handing me a piece of paper? Because my hospital doesn't think it's proof what I see versus what a radiologist sees. Do either of you want to comment about that?
No, I have one very interesting comment about this. When we received our friend Scott Young from Mayo to train in São Paulo, right? He came to São Paulo 10 years ago. And when he went, he spent 1 month with us. And when he went back to Scottsdale, right?
Mayo
and
Clinic.
he started to work with imaging at Mayo Clinic, he delayed almost 2 or 3 years to be allowed to do this exam because it was a long exam. There was no code for the reimbursement. Now he expanded the concept. But again, answering your question, Sally, I think that, of course, in the beginning, you need to prove. The first lectures that I gave, I remember that I was giving a lecture in Argentina in 2008, 1 year after the first publication. And then there was a very famous European guy that was seated beside one of my assistants here in São Paulo, and he was saying, he is lying. he was that I was lying when I was speaking that imaging, and now it became a fever, right? Lots of places are, and we need to work in this concept in the US. We need to work a lot because we need to expand this concept. This will happen. This will help many patients. As you know, Andrea is doing a great job working with imaging. And again, ultrasound is a very good tool. And if we don't have a good ultrasound, MRI can be a good tool if we train also the radiologists for this purpose.
Excellent. So Dr. Vidali and I are going to continue on, but we got to let you go. Do you want to just tell everybody what you are most excited about when it comes to the Endometriosis Summit in March?
No, I am very excited to be with you there and to, again, expand the concept of training colleagues to plan the treatment properly, right? To reduce complications, and everything starts with a good clinical exam. Don't forget that is very important, and a good imaging, right? So if we can expand this concept and plant seeds, right, for sure, we're going to make the future better for this purpose.
Yes, it's going to be awesome. So Dr. Abrao will join us on the main program in what we call a live ultrasound demonstration, and it's going to work much like a live surgery. And then he will be
It's a first, right? I mean, I don't think there's any patient conferences that show that.
He will then be in a lab where he will lead a 4-hour training in ultrasound and MRI and imaging for our physicians track. But most of all, he has to be in the OR in just about 6 hours because Brazil is on a different time. So we're going to say goodnight to him. We love him so much. He and I are going to connect about the technology he needs. And then Dr. Vidali and I are going to continue on.
Thank you, Mauricio. Good night.
Thank you. Thank you.
Say hello to JJ.
Thank you so much.
Bye-bye.
Yes.
Emiliano, of course. Bye-bye. Thank you, Mauricio. Boa noite.
So I have, isn't he great? He was great. I feel bad. It's so late there. I forgot about the daylight savings time. So let's talk nitty gritty. Let's talk about the course. What is pelvic mapping? What is mapping? For those that don't know.
Well, it is what it sounds like it, which is whenever, until now, whenever people got a report, if you go to do an ultrasound, people there's just description, the ovary contain a cyst, and then the uterus looks like a deviated, but in reality, it's not really focused on endometriosis, right? It's a very generic report what you get today when you go to, if you have an ultrasound done at any radiology center. If instead you ask for, or a doctor or the center is able to provide a mapping, they will describe specific areas where endometriosis live. So they will say anterior compartment, the bladder wall. They will say posterior compartment, the torus of the uterus, the posterior part of the uterus, uterosacral ligaments. The description is so much more detailed, the rectum. So it's really a map. It's a roadmap for surgery, if that's what's indicated. This is the difference. It's a roadmap for surgery. So when the doctor gets his document, the surgeon can plan a surgery accordingly. So, for example, invasion of the bowel is going to require the presence, if necessary, of a colorectal surgeon or a urologist if it's on the bladder, if indicated, and things like that. So basically, it's a much more detailed roadmap of the endometriotic disease, which is really what imaging is all about, right? So that people don't go and have these surgeries where the doctor says, oh, we didn't expect this. This was a surprise. And they maybe stop the surgery halfway. And then people have to go back for a second operation, which is a common problem. Sorry, Sally.
I mean, I think, when I was coming up and getting diagnosed, imaging was something we did really to shut me up. Like, here, we sent you for an ultrasound that said you had a cyst, have a good life, there's nothing wrong with you. So I do have a question in that, what is the difference, and you should remember doing this, between when somebody like Harry used to do a pelvic mapping during an exam, and now we're doing it through ultrasound? What is sort of the differences that you see with that?
Well, I think that for a very experienced surgeon, what Dr. Harry, when you say Harry, we're mentioning Dr. Harry Rich, who is one of the fathers of endometriosis surgery. He would just kind of feel and just say there's a nodularity on the uterosacrals, there's nodularity, I feel a rectal mass, and there's obviously value to that. By all means there is, but there are often lesions and implants that are beyond the reach of a hand, of the human hand. And for example, lesions further up on the bowel or up on the pelvic sidewalls, or like, laterally, near the nerve. And, unfortunately, there's a limitation of the physical exam. And also the other part that we have to remember that a lot of the times these manual exams are very uncomfortable for people and very unpleasant. And so I personally prefer to use the ultrasound probe, which is much more gentle, because a physical exam is very uncomfortable, and sometimes you can't really do a good exam because people are very uncomfortable, and it's not something that you could do. When you do an ultrasound very gently, delicately, you could spend 30 minutes looking, whereas nobody's going to do a 30-minute pelvic exam. That would be like torture, basically. So I think that's important to remember.
Yeah, it's interesting. We had a long discussion at AAGL about what if the person can't tolerate even the ultrasound probe. And I thought the first thing is, none of them thought to use vaginal Valium, which, you could give that to the patient the night before. But Dr. Kennedy, who's up in Rochester, was talking about she'll sometimes do it in the OR if she has to. What do you do in the case of severe pelvic floor dysfunction to try to do that mapping with the ultrasound?
Well, what I usually do, first of all, I usually tell the patient that if they think that they're not going to tolerate the exam, it's okay. I mean, there cannot be the perception that this has to be done at all costs. I mean, it can be deferred. So the person, I think the most important element, at least at the beginning, is that the person who gets the ultrasound, who receives the ultrasound, has to need to feel safe. And so I think it's important to communicate that to the patient, saying, look, we may try to do this. If we can do it, good. If we can't do it, it's okay. You need to be able to say, I don't really feel like doing it. I feel too tense about it. So I think all these elements have to be present before you even start doing the ultrasound. The second part is, and I know it sounds like I'm saying something that's kind of obvious to most, but like the insertion of the probe. What I usually do, most instances, I ask the person to insert the probe themselves. And I usually tell them, look, it's for your comfort and privacy. I just kind of move away, remove myself from the table, and let them insert the probe if they can. Maybe they tell me, look, I can't do it, and I don't want to do it. Or some people say, look, for me, it's more difficult, to insert the probe. But I think it's a very good approach, and I've had very good feedback on that. It's a standard way of doing it, by the way.
It's interesting because and we'll talk about it again, but just as we started, we were talking about the portable devices, and the probe is actually much, much thinner. Now, they're not as highly specialized. Well, I can't say that for sure if they are as highly specialized, but for some people, that could be a lot more comfortable as well. Now, do you have a specific order you look at things?
Well, yes. First of all, let me just say my background is because I am a fertility specialist, so I've done decades of ultrasounds, like tens of thousands per year. So let's say that I would say like more experience in ultrasounds than the average person, because I did so much IVF. And IVF, all you do is ultrasound all day long, basically, right?
And you have all the IVF. All you do is have that ultrasound at 6 a.m.
Oh man,
6 a.m. for
so many ultrasounds I've done. But you know what it is, and it's a side note, but this is what we do. A lot of these ultrasounds are so quick, and they just want to look at the ovaries and the follicles, that they miss a lot of stuff sometimes because they're just so focused on just looking at the ovaries, other follicles or no follicles, and the thickness of the lining, that there isn't any real attention to the detail. So what I like to do, I like to follow the path that Dr. Abrao just sort of signaled to us earlier, which is I first identify where the uterus is. I do the famous slide test, which is to make sure that the two surfaces are sliding. If they're not sliding, I look very carefully for some nodules on the
Wait,
bottom.
hold on one second. Anybody who's going, gee, I'd really like a visual. You're going to get visuals at the Endometriosis Summit. We have like almost a full hour on giving you visuals. So you don't have to have them tonight. You just have to have them then. Go ahead, Dr. Vidali.
Yeah. I was looking if I had one, but I don't have it.
No, we're going to have them. Dr. Abrao is going to do it live.
No, I know it's going to be amazing. So I got lost. Yeah. Then I look at the uterus. I always look whether or not there's suspicion of adenomyosis. It's never 100%. Sometimes it's just suspicion. Obviously, it's not a full diagnosis, but you can have suspicion of architectural abnormality on the uterus, whether or not adenomyosis is there. Then I move towards the sides of the uterus. It's called the parametria. I look at the bladder. I look at the ureters coming out from the bladder. I look at the pelvic sidewalls, at the ovaries mobile. I look at the ovaries. Are there any endometriomas? And are they mobile? And additionally, I like to use the Doppler to look at the blood flow in the uterus. That's kind of like a fertility thing, really, because that can affect implantation. And there's actually a score that's based on that. So like you have to go, and I always do the same path every single time. And sometimes if somebody has had an MRI already, I already kind of know what to look for. And it just helps him to confirm things. Like today, for example, I saw somebody had a huge rectal nodule. I already know the nodule was there, so it was very easy for me to find it. But I like to look up with the ultrasound too. And we're going to show a lot of that at the summit. It's going to be very informative, I think. It's going to be helpful for doctors too, definitely.
And when were you talking about? Well, I think all your boys at one point were logged on. Dr. Vidali picked up a large following in Brazil and Venezuela and South America recently. So when is that moment? First of all, what is intraoperative ultrasound and how do you decide when to use it?
Well, I like to use intraoperative ultrasound because sometimes lesions can be hidden. I think that one of the things is that if you look at the pelvis, sometimes there could be lesions that are way deeper. And so like that's one example. Where there's something there, but then you look with the camera and you don't see it, which is a typical situation where stuff gets missed, right? And another example is when you need it is, for example, if you're looking for adenomyosis and you want to remove an adenomyoma, you can't. The uterus may be a little bit deformed, but then you still cannot see the lesion. Another example may be an ovarian cyst, and you're looking at it, you're not sure it's an endometrioma or not. You don't want to just go digging in the ovary. You want to find out and localize the lesion. Another example is the ureters, kind of try to follow them, or the bladder. So there's many instances where an intraoperative ultrasound can be extremely helpful. The thing is that we just talked about is that you got to bring the machine if you don't have it. Like sometimes you got to call for it, but it's a good policy to have.
It's interesting. If you look back, all the Endo Summit lives are recorded on our YouTube. There is an abdominal wall Endo Summit live that Dr. Wasson is actually talking about intraoperative MRI to mark the borders. The endometriosis, the endometrioma on the abdominal wall was so big. They were doing all this, and it's very visual. It's very interesting to look at. So we talked about, this is a lot of pelvic, what I call pelvic. What kind of techniques are coming out to look at the diaphragm, to evaluate the kidneys maybe a little better? What is on the horizon? Because I think so many, especially with the diaphragm, will complain of symptoms for years before anybody listens to them. What's on the horizon for imaging?
Hard. The diaphragm is so hard because imaging of the diaphragm is one of the toughest things because the fact that the liver is attached to the diaphragm and pushes right on it makes it very challenging. And there's not a lot of interface because ultrasound works by having something in between, right? You need, if there's a lot of open space or bone, like the ribs just throw a shadow, and so like you can't really see much. So ultrasound really doesn't help as much unless there's a big lesion, and sometimes there are, and sometimes you can see the mobility of the liver. But when it comes to the kidneys, definitely to make sure that there's no dilation of the kidneys, there's no what's called hydronephrosis, kidney dilation. That's really, really important. And I think that's one of the areas where that gets ignored quite a bit. Just last week, we operated on somebody that had, a significant dilation of their kidney, and had lost already 40% function of their kidney. So that's an interesting example of where ultrasound can be useful. Imaging, honestly, is very important. And the other part of it is, I think it's important that the doctors look at the imaging, because sometimes the report cannot be very informative, can be somewhat informative, but it's always a good idea to look at the imaging. And for the patients, I think I recommend that whenever you're going to see a doctor, you should bring the disc of the ultrasound and of the MRI with you, because ideally it could be very useful information for the doctors,
I will say, as somebody who talks to patients all day long and tries to explain that to them, that oftentimes in our technology world, doctors don't always have the capability to read the discs anymore, because so many of those MRIs are loaded into centralized systems. So if that's the situation, then what we just did it for someone today, the doctor has to have access to that system. Do you know what I mean? Yeah, but not everybody not everybody has it. So like if it's loaded into the Hackensack system, then they have to be able to get and it's easy to get your doctor access when they need it. So like
for example, today, sorry if I interrupt you, Sally. Today somebody told me, oh, I have access to the thing. And I said, look, punch it into my computer. We're not going to save your password. At least we get to look at the ultrasound, at the MRI. And that's what we did. So make sure you when you go, you're prepared with all that information. Sometimes people come and I tell them, did you bring the pictures of the prior surgery? They're like, oh, I forgot. I was like, how can you forget? That's like a very important piece of information. Same thing with the MRI or the ultrasound.
So like, this is the thing. I think that like you can, obviously top level specialists can do a lot of these techniques, but the average person does not have access to a ultrasonographer that knows what, or just a sonographer, because they wouldn't be an ultrasonographer unless they knew this technique. But they don't have access to that. Like, what do we say? I know our answer as an entity is to say that's why we're doing the training, but what else could be the answer to that?
Well, I think in the US, the US is a place we're ahead on some things that would be, like every country, we're ahead on some areas or behind in some areas. I think in the US right now, probably asking for an MRI is the way to go. You know what I'm saying? I think, kind of push your primary care for an MRI with them.
Yeah, but the issue with the MRI is then the guy reading the MRI, and remember the story started 14 MRIs in 1 year.
Right.
Which then ended like a 6-hour surgery where I paid all cash to get it done.
Right.
Because no one would do it. The problem is who's reading that MRI. I get this in the hernia work all the time.
I hear you, but at least you have a document with you. At least you have the disc, and ultimately, it may be helpful. You can do only the best that you can do. And I think at least in the US, demand the MRI sooner rather than later. Also because that saves you time too. So if you show up in a doctor's office, you already have the MRI. You don't have to go back, get the MRI, go back to the doctor, get the MRI review. At least everything is already done. And your primary, if you have a rapport with them, they're likely to order it for you, I think. I think that would be useful. I think that's something to consider, and people can get MRIs done. I see that it doesn't seem to be a major obstacle.
I still think I see a lot of it's you, so I don't have to be as polite as if Dr. Abrao were still here, but I still see a lot of a patient orders an MRI and then, or ask for the MRI. Technically, in some states, the physical therapist can order it if you're not looking for insurance. It's,
Yeah.
but and then it becomes like a weapon. See, I ordered your MRI and there's nothing wrong. But if the person took that MRI, oftentimes people don't know to take the MRI to someone else. And I think like that's my fear. There's a lot of this going on in other countries with ultrasounds, and that it becomes a weapon that the person who is maybe not as trained as they should be is not reading it to the best of anyone else's ability. And then it's a weapon. No, I told you you're fine. You're fine. See, here's the report. And it becomes that's not where the technology is, but that's where people are a lot of times.
It's a risk that you have to take, though, because I feel that not getting the imaging for the fear that's going to come back as a false negative being you still have the disease, but the imaging is negative.
Look, I'm going to be honest. It's going to come back as a false negative, but it's the next step that becomes important.
But, Dr. Abrao didn't say it today, but he said it at the AGL meeting, which is a negative imaging is not an exclusion criteria for surgery if the clinical scenario recommends a surgery. So, a negative imaging, if the clinical signs of endometriosis are there, does not warrant not doing the surgery. I got to make it very clear on that. So, and he said it, and of course everybody else said it, but I think it's important to remember that.
Yes, very, very important. So when it comes to adenomyosis, we used to talk, I know we don't have our buddy here, Dr. Gargiulo, who loves to talk about this, but we used to talk about it was only about the junctional zone. Which it's not really, the junctional zone's not even accurate anymore. What are you seeing on imaging to help you these days?
Adenomyosis is a difficult diagnosis, right? Because what you're looking for, unless it's like a lot and then you see major distortion of the uterus, all sorts of abnormalities that are very, very visible. But for people with minimal adenomyosis, you have to go by subtle signs, which are not 1,000% accurate, such as islands, some speckle pattern in the muscle, which is sign of calcification and old bleeding, small islands of hemorrhage. So you got to look for those small details. And even then, sometimes, you're not 100% accurate, but at least you get an idea of the suspicion. And ultimately, you have to go by the clinical, ultimately, if people have pain or bleeding or those abnormalities. But I think that in the end, one of the things I see a lot of patients, for example, who have IVF failures, implantation failures, who have endometriosis, miscarriages, who have endometriosis, and they have a lot of adenomyosis, significant adenomyosis, very significant sometimes, that is not picked up by the fertility doctors, which is very disappointing. And I think part of it is training, because I think that the focus has gone down in looking for endometriosis, especially on part of the fertility doctors, because they don't think it's important. They don't think endometriosis is a relevant diagnosis to what they do, unless they see a big endometrioma. And I think it's not good. I really hope that this course that we're doing for doctors is going to have some impact. I think it's going to be a very good course. And I think if you're a physician and watching this, I think it's going to be very helpful to you coming to this course with the top people. Do you want to say who these people are going to be running our course in the
it's all on the website.
Look at the website and see it. Exactly.
I just don't think physicians are watching in this moment.
Okay, now that's fine. But if you do,
I do want to say this is that we have this is the first time we've ever done a separate course for physicians only. You have to be licensed to go into this course. Mostly because there's going to be somebody naked. We can't have an unlicensed professional there. So, but we are going to have on the main program 2 different surgeons demonstrating these techniques live. And so I think, we have a little bit for everyone. We have some questions. One question I think is really interesting off of Facebook tonight. So you know how you can take your MRI to someone else? If someone has that ultrasound done locally, is there any value to taking the report to you, or to not just like, or do they do a recording of that, or is there any way?
100%. You can have a disc of your ultrasound given to you, either a disc or images. I usually provide images to my patients, but if you go to like a radiology center, they will give you just like they give you a disc of the MRI, you could have the disc of your image of your ultrasound. 100%.
Yeah.
I have, hundreds of those in my office sitting right now on my desk.
Don't admit that. So he's not behind. He's done all his work.
Okay. Yeah.
Somebody's asking about like how are we advancing the radiology side? So Dr. Vidali and I we would love radiologists at the summit, but we are very much advancing the gynecology side. I'm going to give a shout out only because they're off doing a training tonight. But Scott Young at the Mayo Clinic is training radiologists nationwide, the same way Dr. Abrao and his team are like, have infiltrated every little nook and cranny of Brazil to do trainings. And that's what it's going to take to get every radiologist to know. They're not necessarily always listening.
And one thing that we'd like to observe is that a country like Brazil, which is obviously a wonderful, beautiful country and an amazing country, but it's also a developing country, at least in some parts, some parts more, some parts less. But the penetrance of high quality imaging is being capillary, and you could go to very small towns, very small places, and get extremely good diagnosis for endometriosis, believe it or not. And so it's possible. I mean, education is possible, but it has to come from the educational institution. It has to be institutional, and that's
right.
really one of the problems that
Which
we
is
have.
the power. I think it's amazing what Mayo's doing. I also think should we be approved for CME, it should do a lot for us.
Yeah.
I'm just checking
Mayo's doing an amazing job. There's no question about it. But other institutions do, NYU too, I have to give them credit too.
Somebody is asking like how common is pelvic mapping and how do you request that? Because I know that there are people who go sometimes abroad to get it done.
Well, what's interesting is that it's very hard to get it in the US. I mean, to my knowledge, there's very few places where you could actually get this exam done. You could definitely get it at the Mayo Clinic. You could definitely get it in some parts of Canada because, a lot of they've been trained in Australia, which are the people that Dr. Abrao trained, and then they trained the Canadians in turn. So there was that kind of transmission, but it's very hard to get it, to be honest with you. You could get it at NYU, you get it with me, but you can't really get a very significant, a very well done mapping in many parts of the country.
We encourage you, that's the point of us teaching a mapping course for 4 hours, is to try to look. We have to start somewhere to get people trained, right? Hopefully this works well. What about this?
You could get it in Puerto Rico. You could get it in Puerto Rico.
Yes, our buddy.
No, it's not because it's our buddy.
Get it in Puerto Rico. I believe for the next 26 days, you can get it in Texas because Dr. DeLumba has trained his sonographer, though he's retiring and I don't know what'll happen to her. There are clinics, if the doctor's done the training, they've pushed to have it. What about using this mapping technique to track potential regrowth?
Oh, you absolutely can do that. I mean, it's like I said, it's a great tool. And like, look, good ultrasonographers really see things well. The problem is that there's not that many of them, but it's a great tool. I think it's a very, very helpful tool, and I think I saw somebody today who had surgery in 2018, and they came here, they're like, oh, I'm feeling something. And, we looked very carefully I couldn't see anything, but they were concerned about it. I couldn't see anything. But that doesn't exclude that you could have some regrowth after 5 or 6 years. But at least we felt pretty good that there wasn't anything major, any major sort of implants, anything really visible. But things can happen, and I think it's good to have this as a tool, not just some generic ultrasound look around and that's it,
Yes. Okay. Well, shifting, we hit everything. So let's talk about the Endo Summit. What, I'm not even sure you looked at the program yet. No, I'm just kidding.
First of all, the technology is phenomenal. I think it's beautiful. The way the program is presented, it's just like phenomenal. It's just so great.
So one thing, I didn't want to wear it because I didn't want to upset Dr. Abrao, because one thing, we have our shirts. Endometriosis is not endometrium. And do you have the official one on?
Is this official?
And then there's, of course, the Dr. Vidali version. It's not the fucking endometrium.
Oh my God.
I wore that to tennis one day. They were very offended.
Only Sally could go to the fancy.
I wore it to tennis the day after Dr. Renwine passed away, like in tribute, and they were like, "What are you wearing? This is a curse word." It was very.
She goes to the country club with swear.
So, actually, these are not on sale at the event, or they might be a little on sale. Mm-hmm. But we'll have an event T-shirt. These are on sale in our special pop-up shop. You can get the link for that on our website. And I think we're going to do a course. We are going to do a second course, 2 courses this year, in groin oncology. That's probably my big thing. Yes. I like the white. I didn't order the white. Have, a little hands up on Facebook if you like the white. It looks really good. Looks good with the tattoos. You should wear that more often.
No, I will.
Guys, I saw Dr. Vidali in a red sweater. Not a black sweater. Not
pink sweater. Pink.
I have never seen you in something other than white or black.
Well, now that I'm thinner, I can wear clothing that are less slimming.
Right. Anyway, so I think there's a section in the Endometriosis Summit in the CVent, and I write, our goal is to educate. Okay, fine. But we have set out to create a home for everybody either working in the field or a part of the field as a patient, as a caretaker, because we need a place to come home to. And I think that's what I look forward to the most. And we both of us work really hard to do that. So we hope that you appreciate that. In case you want to attend the summit, the link is in all over the world today. I will say we have a limited number of pre-sale tickets at this price, and they are selling quickly. So buy. Yeah.
And I'd like to say that every year is better. I'd like to thank you, Sally, for doing such an amazing job and putting up with me and my attention deficit.
It's not easy because I also have it. And then it's tough. The other thing I'll say, which we haven't pushed a lot, we're at Margaritaville.
Hey.
First of all, hey, Margaritaville. But second, it's a really good opportunity to, embrace the parrot head lifestyle in the wake of everything that's gone on with Jimmy Buffett. We also, I guess we're waiting. I don't know what we're waiting for. So Nancy Peterson's going to come and keynote.
Yes.
Right?
Yes. This is a very big one. And we like to thank Nancy because we know it's a very big deal for her to come. And, she's making a humongous effort. And I think that it was the passing of Dr. Redwine that sort of like prompted her to say, hey, I got to be there, and somebody's got to hold the banner up there. And I think that's really pretty amazing and very generous of her, of donating her time. And you know, so like we really appreciate her, right? It was just like a big
Yeah.
deal.
I think, you know, Jordan Hutchinson for a long time has asked me what's going to happen when Dr. Redwine isn't here to fight the fight. And all I can say is we fight on, but we are very honored to have Nancy fight on with him in spirit. And she'll be joined by Cindy Mossbrucker, who will help her, you know, in this discussion that the two of them are going to have. And I'm hoping you can see him in our banner. I'm hoping Dr. McKenzie will join us, but I have no confirmation on that yet because he was also trained by Dr. Redwine. Did you know that he went out to Bend?
I do.
Yeah.
And I really hope that he comes, you know, that he comes down. You know, I love
Yeah.
Dr. McKenzie. He's a great lecturer too.
So anyway, this is all the stuff that's going to happen. I'm a little jealous I didn't order the white one. I only ordered the yellow one.
Yeah, man. Check it out.
Yeah, well,
yeah, thank you so much, everybody. And for the patients that I didn't call yet, we're gonna complain that I was online instead of calling them. I'm gonna call you now.
it's our season, 14 weeks. So next week, we are coming at you with international impact of endometriosis. I'm going to try to suck you in from India. We have a lot of international advocates lined up. Some of them, it's 2 a.m. where they are. So I'm really like amazed by that. If you're international and you're looking to have a voice, you should DM me somewhere and we can see. I'm not promising anything. I reached out to Ape. I know Ape is your favorite, but they did not see my message.
I'm gonna send you the message. I'm gonna send you her name right now so we can.
Well, I think they can't. I think it's the American to the Italy thing. So anyway, we'll be back next week and we'll see you soon. Take care.
Thanks, everybody. Thank you, Sally. Lovely to see you.